Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and today we're talking about abdominal aortic aneurysms. And joining us to talk about this is vascular surgeon Dr. Miles Sugar with Willis Knighton Vascular Surgery. Thanks for being here.
Thank you for having me.
Absolutely. So you're a vascular surgeon. I think in the past we've kind of talked about you're like a plumber sometimes for the vascular system. Is that correct? Or
Yeah,
okay.
exactly. Yeah. So my specialty is in the blood vessels that feed the rest of the body.
Yes.
So not the heart, that's the realm of the cardiologist, not the brain, that's the realm of the neurologist and neurosurgeons, but the blood vessels that go everywhere else in your body, that's what I treat.
Okay. Yeah. So I can imagine that it can affect us in a lot of different ways, because that's really a lot of territory there,
Yes,
So we've talked about peripheral arterial disease in the past, and that's something that you definitely treat. But today we are talking about abdominal aortic aneurysms,
Yep.
and we're going to get into all of the things of what this is and how to treat it. So, but first, I think we could, use an anatomy lesson, I'm sure, and what is the aorta, and what is an aneurysm?
Okay.
Maybe start wherever you want.
So the aorta is the main blood vessel. So it starts right as it exits the heart, and it travels along the front side of your backbone all the way down to about the level of your belly button. And then it splits in two to then feed blood down to each leg. So that's the aorta. An aneurysm is just a word that means it's a blood vessel that's larger than it should be. So for the aorta, where an aorta is in this area is supposed to be about 2 centimeters, or about 1 inch across. Anything that's more than 3 centimeters or 1.5 inches across, that's larger than it should be. So that's an aneurysm.
Okay.
The reason that we care about that is as these aneurysms get larger, there's a risk that they could burst. And when they burst, that can result in a life-threatening internal bleeding.
Right. Yeah, and I'm sure everybody's heard, if you have that burst aneurysm, whether that's in your brain or, of course, in your abdominal, or it can happen anywhere as well, or is it the two common places?
Those are the most common.
Okay.
You can get an aneurysm of any blood vessel anywhere in the body. But the most common places that we see it, the most publicly known one is brain aneurysms.
Right.
But we also see them very commonly in the abdominal aorta. You can also get them higher up in the aorta and the chest. But most commonly outside of the brain, what we call peripheral aneurysms, is the abdominal aorta.
Gotcha. Okay. And this can, as you mentioned, be a severe life-threatening thing if it bursts. And of course, in some situations, you may not know that you have an aneurysm or a larger blood vessel. Would you say that's correct?
Yes. So most of these we find accidentally. Patient goes into the emergency room or goes into the regular doctor and gets a CAT scan for some other reason, looking at a colon infection, a kidney stone, and on that CAT scan, they happen to see that the aorta is larger than it should be. When we catch them that way, that gives us the opportunity to go in and fix these before we get into that life-threatening situation. If we don't find them that way, then these are patients who show up to the emergency room very sick. They've got severe pain and their blood pressure is low because they're losing a lot of blood. And that's a real emergency, a life-threatening situation there.
Yeah, and I guess to distinguish between, the presence of an aneurysm, you may not have symptoms, but if it bursts, then you're going to have those symptoms, right?
Yes, so in general, you don't have the type of nerves around this aneurysm to feel that it's large. So they only start to cause pain when they're trying to tear or push things out of the way. So you can have a very large aneurysm and never notice it until when they start to hurt, that's a sign of problems.
Yeah, okay. Someone might be, or I'm wondering, I'm curious, with having the presence of an aneurysm with the aortic or the aorta, why is this a bad thing? What is happening in the body with the blood being transferred with that larger area?
So as far as blood flow and what the aorta is doing, Rarely do we see these aneurysms interfere with that blood flow. They can. You can build up a little bit of clot in the aneurysm. It can go and block off blood vessels in other parts of the body. But most commonly, the blood is flowing through it just fine. It's that potential for the rupture. And as these aneurysms get older, they get larger. And as they get larger, then they're more likely to have that rupture event. And so this is something that is, some patients will say it's like they have a ticking time bomb. It's not causing any problems right now, but when it does, it can be a big one.
Yeah, okay. And as it's getting larger over time, it's just, is it weakening just the integrity of the wall of your vessel?
Yes, so as the walls get stretched, they get weaker.
Gotcha.
And so then they're more likely to stretch further.
Yeah, okay. Well, how does this happen? Is this something that's genetic or hereditary, or can this happen to anyone?
Sure, so there are some genetic components to these. They seem to run in families. They don't run in the same families that brain aneurysms do. So it seems to be a separation there.
Okay.
But by and large, the ones that we see are not the ones that run in families. So this can happen to anyone. It's more common in men than in women. It has a lot of the same risk factors as your other peripheral arterial disease or coronary artery disease, where it's blood pressure, it's cholesterol, it's things like that. But also smoking is a particularly large risk factor for this.
Yes, okay. And I know we've talked about this before in the past, but tell us why smoking is, well, obviously there's many reasons why we shouldn't smoke, but specifically for your blood vessels, what does it do?
Yeah, so short answer is a lot of that we don't know yet.
Okay.
But what we find is that individuals who smoke or use tobacco products, their arteries get diseased at a higher rate, at a faster pace, and they then can suffer from things like these aneurysms or from blockages in their arteries that is much less common than in a population of patients who don't smoke. So it damages part of the walls of the arteries and causes the arteries to react in this way that causes these problems.
Gotcha, yeah. Okay, well, definitely something to be aware of if you are a smoker. Then, make sure, there's many other reasons why you probably shouldn't smoke as well. But if you're just joining us, we have those phone lines open. You see that right there on your screen. That number is 318-219-4569. You can give us a call and talk directly with Dr. Sugar if you have a specific question. He is a vascular surgeon, so we're directing those questions to that topic. But we are talking about abdominal aortic aneurysms, and so if you have a specific question about that, or if you are, maybe think you have some symptoms associated with that, maybe call 911 first before calling us, right?
Yes. So yeah, definitely if you're having that severe back pain or belly pain, that's always something that should be checked out. Now I know a lot of us have chronic back pain. That is not what this is. So patients that I've had who have chronic back pain and have symptomatic aneurysms, they can tell the difference between those pains. So if you have longstanding back pain, you've been working on that with your doctor, that's very unlikely to be related to a problem like this.
Yeah, it's probably more of that acute pain, sudden, severe.
Exactly.
Okay, and it's also in your abdominals as well. You'll experience that as
so in the lower abdomen and typically in the lower back as well.
Okay, because that's where your aorta is.
Exactly.
Okay, got it. Okay, so is there any way we can prevent this from happening?
So preventing the aneurysms we're not as good at right now. Stopping smoking is one of the big things there. But what we do is try to preemptively treat these. So if we can find these aneurysms before we're at the rupture situation, then these can be fixed in a planned, scheduled surgery to then eliminate or severely reduce that risk of rupture moving forward.
Okay, and so we've talked about the diagnosis of it, and you mentioned that a lot of times someone goes in for a CAT scan and they find this. Can you see, or if you were looking at someone's scan, do you know, or you can kind of see it immediately, I guess, because you're so used to looking at those types of scans, or is that something that easily is detectable?
So in a CAT scan or an MRI that shows this area of the body, it is readily apparent
Okay.
to either a radiologist who's looking at that or anyone who knows what they're looking at there. So oftentimes we get a patient who had an MRI of their back and we can't see all the details of it, but we can tell that there's an aneurysm there. We need to get that checked out.
Okay. Okay. So yeah, it's pretty apparent. So that's pretty interesting. So, so talking about diagnosis, so what they probably refer to you once they find that. So now we're looking at that planned treatment. So what does that look like? I'm sure maybe it's different depending on the severity.
Exactly. So depending on the size of the aneurysm, that's been found to correlate with the risk of rupture. So for the smaller aneurysms, oftentimes the answer is we don't do anything at this point. We keep an eye on it. We do CAT scans or ultrasounds every year or so, and we watch for growth. If we see that growth, or if we see it grows to a certain size cutoff, at that point we start talking about surgical options. There are two main ways to repair these now. There's a traditional surgery, which is a open belly operation where we actually get the aneurysm and replace it with a plastic tube. So we sew a tube in place to replace that area of the aorta. Now there's been a development in what's called an endovascular repair of these aneurysms, which is what's called a stent graft. So what a stent graft is if you think of a traditional stent, like a heart stent that a lot of patients would be familiar with, I use the analogy of it's a chicken wire fence.
Okay.
It's a metal scaffolding, and its job is to prop things open that want to shut down. With a stent graft, if you take that same type of stent and you wrap a fabric around it so that now that stent is watertight. What we're able to do then is to go in and get a watertight seal above the aneurysm and a watertight seal below the aneurysm, channel blood through this stent graft. So we're no longer removing the aneurysm, but we're sealing it away from the blood flow. It's very similar to how they reline sewer pipes nowadays. Don't actually have to oftentimes dig out the problem, but they can put a lining in there that seals it so that nothing can leak out.
Gotcha. Okay. And when you're talking about, finding that site of the aneurysm, can it happen anywhere on the aorta, or does it happen?
It can happen anywhere on the aorta. The most common place that we see it is between where the kidneys are and where it splits into to go to each leg. And so the stent grafts, a lot of them are specially designed to fit in that area.
Gotcha.
It can occur in other areas, and there are more complex stents that are available for those areas. And a lot of that's in development now, because when you get up higher than that, you've got arteries that go to your kidneys, arteries that go to all of your intestines and internal organs. And so you can't put a watertight seal across those, because then you're shutting off blood flow to places it needs to be. And so we have specialty stents that, some of them still in development, to be able to seal aneurysms in that area without cutting off blood flow to vital organs.
Yeah, okay. And I've also heard aneurysms described as like a bulging. Is that correct in this situation?
Yes.
Okay.
So when we see an aneurysm on a blood vessel, this is a little bit of the medical student version of the lecture here, but they come in two shapes generally. One is what we call a fusiform or torpedo shaped, and that's just generally the whole thing has swollen. You can also have what's called a saccular aneurysm, which is a bulge that comes out towards one side. If you were to squeeze a balloon in your hand and that little part pops out between your fingers, that's what the saccular aneurysm is. Those are less predictable than the generalized swelling ones. So those get fixed earlier because we don't know what their risk of rupture could be.
Gotcha. Okay, that makes sense. And that makes sense how you can see that on a CAT scan pretty easily.
Exactly.
Too. So, okay, and so yeah, it's really serious if you find yourself in a situation where it bursts. And so, is that something that needs immediate attention? And how long?
Immediate.
Okay.
Yeah, that is, do not pass go, do not finish what you're doing. Call 911, get to the nearest hospital. even if that hospital does not have the capabilities of fixing what you have, they have the capabilities of getting you where you need to be into the hands of someone who can fix that faster than you can with your own car.
Okay, so call 911.
Yes.
Yeah, because they can start working before you even get to the hospital. So definitely important there. And you know, especially if you're by yourself and driving to the ER, you know, you're in so much pain. Is there any other symptoms other than the pain that could manifest, or is that pretty much the common one?
That's pretty much, most patients don't know that anything is going on until that pain starts.
Okay.
And so this is all about trying to find it early, trying to fix it early, try and keep us from being in that situation.
Mm-hmm. And then I'm sure once they get to the emergency room, do they have to rule out other things? Because it could be a number of different things going on when you have abdominal pain and back pain, or is it pretty indicative?
Usually, if you have someone who's as sick as you would be coming into the emergency room with that type of pain, there's a CAT scan that's done pretty immediately, and then that rules in this and rules out most everything else very quickly, and then it's a race to the operating room.
Okay, and so in that situation, you're probably not looking at stents, or are you in that situation?
You can.
Okay.
It depends on how equipped your facility is to deal with those stents, because with the stents we also have balloons, and so what we can do when you have a rupture event is we can go in with the same tools that we're using to put the stent in and put a balloon up that serves to block the blood flow going into that area, gives us time to catch up and then to put the stent in to get the bleeding under control.
Gotcha. Okay. And so that would be kind of in that emergency situation. But if you're planning, you have a little bit more, I guess, options in that way, right? So you have the stent, and it depends on where it is, what type of aneurysm you have. What other, advances have you seen in treating this?
So a lot of the advances in the treatment of this has to do with the preserving blood flow to those vital organs as we get higher and higher up in the abdomen. So there's a nice kind of area below the kidneys before the split to go to each leg that's fairly straightforward to treat. And then as you get higher, you then have to involve the arteries to the kidneys. And so we have been developing stents that then have holes cut in them to be able to get preserved blood flow to get just into those arteries without still getting blood into the aneurysm. And if the aneurysm extends even higher than that, then we're getting into blood flow to the liver, blood flow to the intestines, and having extra branches available to be able to preserve those. Some of that's not yet commercially available, but it's what's being developed right now.
Okay, so that could be something coming down the line soon. So, this is something obviously very serious, and we want to take it, not take it lightly when and if it does happen. But what are some of those potential maybe disadvantages and advantages of each types of surgery that you've mentioned?
Sure. So the open surgery, the traditional surgery, that's a major open operation that usually is accompanied by about a week in the hospital, the majority of that in the ICU. And there are complications that can be associated with that, like any major open surgery. Also problems with blood flow to the legs and things like that. With the stents are relatively new. They've been around since the late 80s now, so it's not as new. But so as far as the long-term data on these, we don't have a lot of that yet. So a lot of that's being developed. But you can have problems with leaks around the stents shifting, things like that. And so the stents we keep a close eye on for much longer than we do someone who's successfully had an open repair.
Gotcha. Well, we have our first caller and first question. Kalia, thanks for joining us. And what's your question for Dr. Sugar today?
Would a aneurysm in the stomach be seen, or maybe the evidence of it, on an endoscopic?
Rarely. There can be some situations where if you have an aneurysm that is close enough to that part of the intestines, or you have an aneurysm that is large enough, you could actually see pulsations on the endoscopic study that would kind of hint towards having an aneurysm. But the aortic aneurysms that we typically see would not be visible on a test. I would not count on an endoscopic test to rule out that you would have an aneurysm.
Okay. One more question.
Sure.
Would a hiatal hernia on your stomach close to the heart, would that be something to worry about for an aneurysm?
No, so that would be unrelated to an aneurysm. They can both, having that and an aneurysm, they can both complicate the treatment of each other because they're very close to each other. But having that hiatal hernia next to the aorta is unlikely to affect the aorta in a way that would make it more likely or more risky to have an aneurysm.
Okay. Well, thank you, and you have a great day, sir.
You're welcome. You too.
Yeah, thanks for your question. And
Bye-bye.
if you have a question and you're just joining us, we're talking with Dr. Miles Sugar, a vascular surgeon with Willis Knighton Vascular Surgery. You can give us a call. That number is 318-219-4569. And Jim, thanks for joining us. And what's your question?
Yes, it's kind of a general question of what he might recommend, if there is a recommendation of vitamins. If you know you come from your family line, there's been some cerebral aneurysms, but also, like personally, I've suffered from muscular problems in my legs. Is there a vitamin that's just good in general to, I don't know if it'd bring back elasticity or just is in?
I'm sorry, you've broken
any
up a
kind of
little
medicine.
bit, but I believe you're asking about a vitamin or something to help with the blood vessels.
Yes,
Not
and to
one in
prevent these problems, to prevent the problems all you're describing.
Sure. Not a vitamin per se, at least not that I'm aware of. A lot of this is about, number one, avoiding tobacco exposure. Number two is going to be a lot of those things that your regular doctor is going to be working with you on as far as blood pressure control and medicines for that, cholesterol control, medicines for that, things like that. But unfortunately, there's not a good over-the-counter supplement that's going to help break down plaque buildup in your arteries or to help strengthen the wall of your aorta. Unfortunately, we don't have something available like that at this point.
All right, thank you.
You're welcome.
Yeah, thanks, Jim, for that question. Yeah, so a lot of it is your typical things that you would want to avoid in terms of heart disease as well. It kind of seems like it goes hand in hand when you're talking about
Exactly.
the vessels in the heart.
Yes.
Okay.
So because a lot of heart disease is actually the blood vessels of the heart that are having the problem.
Right.
And so the disease that affects the blood vessels of the heart can also affect the blood vessels elsewhere in the body. And so a lot of the prevention and treatment is very similar.
Yeah, that makes sense. So yeah, because you have a lot of blood vessels around your heart. We've got our lawn care going on. I'm sure people can hear that right now. But you know, the blood vessels in your heart, they're a lot smaller, right? And so, but you know, so definitely, you know, you want to practice all of these things. The lawn care is really throwing me off right now. Anyways, moving on. So let's say we've had the surgery. You know, they visited you and they're in the ICU, so it's a pretty extensive recovery because most of the time it's an open surgery.
So most of the time nowadays we're able to do it as a stent graft.
Oh, okay.
So the open surgery is a major surgery, and that's a ICU stay. The stent graft surgery, when we do that, similar to when you're doing your heart stents, it's done through needle sticks down in the groin.
Okay.
And so you end up with, they're a little bit larger than your traditional needle stick, but 2 nicks, one on each side of the groin, that usually when you come back to clinic, you're not able to find them. And that's typically just a 24-hour hospital stay. We watch you overnight in the ICU, make sure that everything's sealed the way it needs to, nothing's bleeding, anything like that. And if everything goes well after the stent graft surgery, go home the next morning after breakfast.
Nice, and that's mostly for the preventative side of things when you catch it early.
Yes, that's definitely when you catch it and you do these as an elective surgery.
Yeah.
For the patients who come in emergently with a rupture, that could be a much longer hospital stay because then we have to deal with the after effects of a significant blood loss event.
So let's say someone had found the aneurysm through routine screenings and they elected to have the surgery with you with the non-invasive way, do they even notice a difference in symptoms, or maybe they say afterward, wow, I actually do feel better, or do they not notice anything at all?
Typically they don't notice anything
Okay.
at all. If they do feel better, I try to take credit for that. But in general, this is something that doesn't cause chronic problems until it causes the acute problem.
Right.
And so these are patients who felt fine beforehand, and my goal is for them to continue to feel just as fine after surgery.
Cool. Okay. And obviously, with the ones that came in emergently with that acute severe pain, I'm sure they feel pretty good
They
after.
feel much better immediately. Yes.
Okay. Okay. I mean, of course, once they get over the extensive surgery, because I'm sure that's
Correct.
pretty painful. And how long are what's your typical recommendation for them to wait to get back to normal activities?
So after any sort of major abdominal surgery, rule of thumb is about 6 weeks before we start lifting anything heavier than 10 pounds. The gallon of milk is what we kind of use as a good reference for that. So 6 weeks after a major abdominal operation, if you come into the hospital with a rupture event and we're able to do a stent graft repair, it could be shorter, 2 to 4 weeks. With the elective surgery, we ask you that you take it easy for a couple of days, just to make sure that the groin stick sites heal up, but other than that, return to normal activity.
Okay, not bad. All right. And so what is that long-term prognosis for someone who has had that aortic aneurysm? Do they continue to live normal lives, or do they have to worry about this happening again? What typically happens?
Yeah, so once the aneurysm is repaired, then most of the risk should be gone. At least that's the goal of the surgery. We keep an eye on these long term with routine CAT scans to make sure that parts of the stent aren't shifting, that we're not seeing leaks or anything like that. What we should see after that is that the aneurysm, because we didn't remove it when we've done the stent, that aneurysm starts to shrink down now that it's no longer getting that blood pressure. If we are not seeing that, then we become concerned that maybe there's a leak somewhere, something's not sealed up the way it should be, and we may have to go back in and do minor procedures to try and fix that.
Okay, and the hardware, I guess, that you're using, does that stay, let's say this happens to a young person. I'm sure it's maybe more common in older individuals, would you say?
Yes, it's more common in older individuals. The materials that we are putting in the body, either for the open surgery or for the stent graft repair, both of those are intended to last as long as you do.
Okay.
So that's something that there's no plan to go back in and take things out after a certain time period or anything like that. These are meant as permanent replacement body parts.
Gotcha. Any medication needed after the procedure usually?
Not routinely.
Okay. Unless I guess you were already on, cholesterol lowering medication and that kind of stuff.
Yes. The routine kind of risk reducing cardiovascular medications. In some cases, with some of those smaller branch graft, those newer devices, there are additional blood thinners that are needed for that. But after a routine aneurysm repair, there's no additional blood thinners or anything like that we typically add.
Okay, gotcha. And so how often will they follow up with you after the procedure?
So after the procedure, I do a schedule of a CAT scan at 1 month, 3 months, 6 months, and then once a year for the rest of your life.
Gotcha. All right.
And we become good friends. I tell them that this is not something you need to worry about. This is something I need to worry about. And we just follow it. And as long as the aneurysm behaves, we leave it alone.
Nice. Well, we've got less than a minute left, and so we want people to know where to find you. Hopefully they don't have to see you in an emergency situation, but if someone, I guess, needed your level of expertise, where can they find you?
So I'm at Willis Knighton North on Glenwood Road. And our office phone number is 318-212-8177. We're in the Medical Arts Building.
All right, and something that might be more common that they may see you for is that peripheral arterial disease.
Exactly.
So, and that's something that happens chronically as well. And we've talked about that before on Healthline, and you can catch this episode and previous episodes with Dr. Sugar on our website. That's ktbs.com/podcast or wherever you get your podcasts. Thanks for joining us.